Welcome. My name is Tytti Massinen, and I work as a global business manager within PerkinElmer Maternal Fetal Health Team. I am hosting today's lecture, which is given by Professor Kypros Nicolaides from King's College Hospital, London. The lecture is entitled Pre-eclampsia, Prediction and Prevention. The webcast will be recorded, and the recording will be placed on PerkinElmer web pages, and we will let you know as soon as it is available there. Now it is time to start the lecture.
I will discuss some of the latest developments for the prediction and prevention of preeclampsia. Preeclampsia is one of the main causes of death and handicap for both the baby and the mother. And not only that, but also in the long term, pregnancies that were complicated by preeclampsia are at increased risk for both the mother and the baby of developing cardiovascular disorders and diabetes type 2. So it is an important health problem, and it would therefore be very useful if we could identify in the beginning of the pregnancy those women that are at high risk of developing preeclampsia, and then through pharmacological or other interventions to reduce the prevalence of the disease. The traditional approach to identifying the high-risk pregnancies is to ask women a series of questions at the beginning of the pregnancy. And in England, the National Screening Committee, the government, the Royal College of Obstetricians are recommending that we should use this approach at the first hospital visit of all pregnant women. Essentially, we ask them 5 questions, and if the answer to those is yes, then the women are classified as being at high risk. And then we ask them another 5 questions, and if the response is positive to 2 out of these 5 questions, again, they are classified as being at high risk. A similar approach is used in the United States, where here all of the methods, all of the questions apparently have the same importance, and if your answer to any one of these questions is positive, then you're classified as being at high risk. So throughout the world, it is recognized that it is important when we first see a pregnant woman to try to work out whether they're at high or low risk of developing preeclampsia. And in many countries, women identified by these methods as being at high risk are being recommended to take low-dose aspirin, which varies in different countries from something like 60 to 80 milligrams. Unfortunately, these methods have not been validated, so we cannot really tell whether they're useful in identifying the high-risk pregnancies, what is their detection rate, what is their false positive rate. In the last 10 years, we have developed a new approach to defining the individual patient risk for preeclampsia that can be applied at the beginning of the pregnancy during their routine 11 to 13 week scan. The basis of this method is to ask the women a series of questions very similar to those that are being used in the American College recommendations or in the NICE guidelines in England. But rather than consider each one of these maternal factors as independent and unrelated events, we use a multiple regression approach which attributes the importance to each one, the relative importance to each one of these factors, and their interrelationship. For example, the fact that a woman starts a pregnancy with a history of chronic hypertension is by far more important than if she starts the pregnancy by being diabetic or by being of Afro-Caribbean or black racial origin. So we use factors from the demographic characteristics, from the medical history and the previous obstetric history, and we allocate the relative importance to each one of the factors and their interrelationship. The second thing that you have done is we used a survival type model to define the risk for preeclampsia. This model assumes that if pregnancies were to continue indefinitely, then all women will develop preeclampsia, and whether in reality they do so or not depends on competition between delivering with preeclampsia or delivering for any other reason other than having preeclampsia. The average risk population will, we hypothesized, develop preeclampsia at around 55 weeks. I know this sounds absurd, but the implication of this is that very few women will actually present with preeclampsia before they deliver for any other reason. So in an average risk population, the chances that the woman will develop preeclampsia are about 2 to 3%. Now, if we take the various risk factors and we define their importance in terms of their ability to shift this gestational age distribution of delivery with preeclampsia either to the left or to the right of the average, then in a woman that has very low risk for preeclampsia, the whole graph is shifted to the right, with the implication that by far the vast majority of women will deliver for reasons other than preeclampsia. And if you have a series of different risk factors that place you at a high risk of developing preeclampsia, your graph is shifted to the left so that many more women will develop preeclampsia before they actually deliver for some other reason. The implications of this approach are that we treat preeclampsia as a continuum, and we are able to give for each woman, based on this mixture of factors in their history and characteristics, an individualized chance of delivering with preeclampsia at any required gestation. So it can do away with defining preeclampsia as being early or intermediate or late. Every woman has an individual risk of developing preeclampsia that can be quantified for each week of gestation. Once we establish this background or prior risk, then we can see what is the effect of various biomarkers. And the biomarkers will then influence your prior risk. This is not very different from screening, for example, for Down syndrome, where everybody starts off with a prior risk, which is based on their maternal age, and then we modify this risk based on the results of biochemical analytes and ultrasound findings. Extensive research in the last 10 years involving tens of thousands of pregnant women have now established that there are 4 important biomarkers for preeclampsia in the first trimester of pregnancy. And these are the Doppler assessment of the uterine artery pulsatility index, the measurement of the mean arterial pressure, the measurement of the maternal serum PAB-A and maternal serum PLGF. And on these graphs, you can see the black dots, which are pregnancies with preeclampsia, plotted against the gestational age at which women delivered with preeclampsia. And there are 2 points that you can easily see. The first one is that in the case of uterine artery pulsatility index and mean arterial pressure, the levels in women that develop preeclampsia are higher than the blue horizontal line, which denotes the average value for women that do not develop preeclampsia. And in the case of PAB-A and PLGF, the levels are lower than in non-affected pregnancies. The second point that is very clear is that the earlier in pregnancy you develop preeclampsia, the more severe the disease, the greater is the deviation from normal for each one of these markers. And that is why you have these oblique purple lines, which are the regression lines of the relationship of each one of the biomarkers with the gestational age at delivery with preeclampsia. So at the 12th week of pregnancy, women that will develop severe early onset preeclampsia will have much higher levels of uterine artery pulsatility index, mean arterial pressure, and much lower levels of PAB-A and PLGF than women that develop preeclampsia after 37 weeks. So I summarize here the method. We combine the information from the maternal history and maternal characteristics with the measurement of the mean arterial pressure, the uterine artery pulsatility index, and the maternal serum PAB-A and PLGF. And in a recent study involving nearly 40,000 pregnancies that we screened at 11 to 13 weeks using this method, we found 2 things. Firstly, the so-called triple test that combines uterine artery pulsatility index, mean arterial pressure, and placental growth factor is as good as if we also measure PAB-A. So we can therefore confine the test to those 3 markers. The second point is that with this approach at 12 weeks, we can identify about 90% of the women that will develop very onset preeclampsia before 32 weeks, about 75% of those that will develop preterm preeclampsia before 37 weeks, and a bit less than 50% of those that develop preeclampsia at term. So our method is good for the prediction of preterm and less good for the prediction of term preeclampsia. And this slide shows the value of each individual marker for the prediction of preterm preeclampsia. And you can see again that the best prediction is achieved by using the triple test. And the same is true in the case of the prediction of term preeclampsia, where overall the performance is much less than the detection of preterm preeclampsia. In all of our studies, we collected a lot of data from tens of thousands of women. We developed the mathematical model for the prediction of preeclampsia. And then, of course, we tested the same model on the same data that we used for the development of the model. And this approach, of course, introduces an optimistic bias. Our performance could be better than if the test is applied in a different population. We therefore wanted to validate or to examine the validity of our algorithm in a prospective multi-center study. And with the support of a grant from the European Union, we developed a group of collaborators from various obstetric and fetal medicine centers in Spain, in Italy, in Greece, and in England, and with the collaboration of the industry, Perkin-Elmer, and Viewpoint and Astraea, the software companies, we undertook this non-intervention screening study involving nearly 10,000 pregnancies. We applied the mathematical model that you had previously developed, and we screened these women using maternal history together with the measurement of the biophysical and biochemical tests. And in this population of women, 2.7% developed preeclampsia. And these are the predicted results for preeclampsia before 32, preeclampsia before 37, and preeclampsia at or after 37 weeks. And these are the results that we obtained from the study, which were nearly identical, or certainly in the case of very early preeclampsia, even better than we predicted. And therefore, the model has now been validated in a major study involving different centers. So you can assume that this is an accurate method of identifying the high-risk group for preeclampsia. 90% for preeclampsia before 32 weeks, about 75% for preeclampsia at less than 37 weeks, and about 45 to 50% for term preeclampsia. We wanted then to examine how good the traditional methods of screening are. And in this slide, the purple histograms show the value of the NICE guidelines used in England for the prediction of preeclampsia. And you can see that the performance of screening is not great. We can identify less than half of the cases of preeclampsia. And I superimpose on the graph the blue histograms that are the values that you obtain by using the Fetal Medicine Foundation method of combined screening, which you can see that for the same number of screen positives, which is about 10%, the performance of screening by our method is by far superior than that used in England, particularly for preterm and very early preeclampsia. This slide examines the value of the approach used in the United States. Here, again, each one of the risk factors is considered to be an independent factor, and several factors are combined together to identify the high-risk group. You can see that the performance is quite good if we just look at the detection rate, but unfortunately, the false positive rate is extremely high, and more than 2/3 of the whole population are classified as being at high risk. And the blue are our histograms. By comparison, the performance is similar, but now we only have a screen positive rate of 10 rather than more than 65%. So the conclusion from these studies is that we have a very good method at 11 to 13 weeks of identifying a high-risk group for the development of preterm preeclampsia, and the method that combines maternal history and characteristics with biophysical and biochemical tests is by far superior than the methods that are currently used throughout the world. The British government has now given us a scholarship to again compare our method with that recommended and carried out routinely in Britain. We have screened in a series of different centers in England nearly 17,000 pregnancies, and we have to wait until June when all of these women deliver so that we can compare our method with that is being used at the moment. But my prediction is that there is no reason to believe that the results would be any different than those that I have already presented in relation to the screening quality study. What is important, however, from my point of view, is that this study is supported and funded by the British government. It is very likely that if we get very similar results as with our screening quality study that show that our approach is by far superior by the current method, then my expectation is that the National Screening Committee will be recommending a major change in the method of screening and adoption of our method like they did more than 10 years ago when they are adopting our method of screening for Down syndrome by the combined test in the first trimester of pregnancy. So we have a good method of identifying the high-risk group, and now we have to look at interventions that may be able to reduce the chances of a woman that has been identified as being at high risk of actually developing the disease. And this slide gives us a historical perspective on the development of aspirin. More than 3,000 years ago, the potential value of this medication has been utilized in ancient Egypt and then subsequently in Greece over the centuries as a drug that can have pain-relieving and anti-inflammatory properties. And eventually, the drug was developed into the commonly used aspirin, and even a Nobel Prize has been won by researchers that have clarified the likely method by which the drug operates. And we know that this is one of the most widely used, if not the most widely used, medication throughout the world. The possible value of aspirin in the prevention of preeclampsia was raised more than 20 years ago by a small study in France, where women that were identified as being at high risk of developing preeclampsia were randomly allocated into a group that received aspirin, 150 milligrams, or placebo, starting from the 12th week of pregnancy. The number of cases examined was extremely small, but this study, for the first time, highlighted the potential of using aspirin at 150 milligrams starting from 12 weeks for the prevention of the development of preeclampsia and fetal growth restriction. Subsequently, many different studies were undertaken where different doses of aspirin were used, starting from 60 milligrams right through to 150, but in the vast majority of studies, the dose was less than 100 milligrams. And the studies recruited patients from the first but mostly from the second trimester of pregnancy. And this is a meta-analysis putting the various studies that have been published until the time together. And this study found that we can reduce the rate of preeclampsia in a high-risk group by only about 10%. In 2003, we undertook a major screening study in the second trimester of pregnancy, and we used uterine artery Doppler to identify the group with impaired placentation, and then we randomized those with abnormal Doppler into receiving 150 milligrams of aspirin per day starting from 23 weeks, and another group that were receiving placebo. This was a major effort which unfortunately produced negative results. Aspirin did not reduce the rate of total preeclampsia or preterm preeclampsia or delivery of small babies or perinatal death or abruption. And therefore, we concluded at the time that in a high-risk group of women, the use of aspirin, 150 milligrams, initiated after 23 weeks of pregnancy, is not beneficial. Subsequently, Emmanuel Bujold in Canada undertook a meta-analysis of all of the various randomized studies on the use of aspirin and concluded from the previous studies that if aspirin is given at gestations beyond 16 weeks, it is not beneficial, but if aspirin is initiated before 16 weeks, there is a major benefit with a reduction of about 50%, not only in the rate of preeclampsia, but also of fetal growth restriction and perinatal death. Indeed, when the data were analyzed further, it appeared that aspirin was particularly useful for the prevention of preterm rather than term preeclampsia. The major criticism against this meta-analysis is that the number of previous randomized studies that provided data was very small, was very limited, and there was a question as to whether this was a chance finding or a true finding. If we were going to do a study in which we should give aspirin, we would have to demonstrate that it is beneficial to identify a high-risk group and then give to such a group aspirin and then demonstrate that the rate of preeclampsia or other adverse pregnancy outcomes was reduced. An alternative view is that why bother doing a major screening study to identify the high-risk group? If aspirin is safe because everybody is using aspirin all of the time, why don't we just give aspirin to everybody? Our life would be much simpler if we did so. The reason for that is very simple. The rate of preeclampsia is relatively low, and we would be unnecessarily subjecting an extremely high proportion of the population to a medication that, although it appears to be safe, it may not be completely safe. And the results from this study, a major study in Italy, where adults are given prophylactic aspirin, has shown that, unfortunately, the use of low-dose aspirin is associated with an increase in the rate of major hemorrhagic events. And therefore, even if the overall risk for such major hemorrhagic events is very low, if we were going to treat the whole population for a relatively rare condition, inevitably we may end up with a conclusion that aspirin produces more harm than good. It is therefore critically important in my mind that before we use aspirin, we should be identifying a high-risk group that may benefit from such treatment. If we were to construct a study, then we need to address a series of other questions. How much aspirin should we be using? I think it is important that the dose should be 150 to 160 milligrams, because we do know that at lower doses of aspirin, a high proportion of the population is non-responsive. Aspirin does not alter platelet function in about 30% of women if the dose is too low. So if you were really interested in defining whether aspirin is useful or not, we should be giving a sufficient amount of the medication to see its effectiveness. Another question that is important is the timing, and on the basis of the meta-analysis from Bujold, the timing should clearly be before 16 weeks, and in my mind, it should preferably be at the 12th week of pregnancy, after the application of our approach to screening and identification of the high-risk group. And when should we stop with aspirin? Well, although the existing data from previous randomized studies suggests that aspirin is safe, in reality, very few of the previous studies have given 150 milligrams, and there is always a remaining fear that aspirin at 150 milligrams may increase the risk of hemorrhagic events in both the mother nearer the time of delivery and the neonate. And therefore, we should be stopping the medication at around 36 weeks. Another question that has been raised is as to which is the best time during the day that we should be treating the women. And there are a series of studies that have monitored the effectiveness of aspirin in terms of its effect on blood pressure by giving the drug either in the morning or in the afternoon or in the night. And these studies suggest that the best time for receiving aspirin is at bedtime. And the final question is, what should be the outcome of such a trial? Should we be looking at total preeclampsia or preterm preeclampsia? It is clear from the meta-analysis of Bujold that aspirin, if it is effective mainly in women that develop preeclampsia before rather than preeclampsia after 37 weeks. And therefore the target for the intervention as an outcome measure should be preterm rather than overall preeclampsia. And then of course, how should we be identifying the high-risk group to participate in such a study? It is obvious that the Fetal Medicine Foundation algorithm should be used as being the best performing way of identifying the high-risk group early enough for such intervention. So after many years of planning, we started the ASPRI study, which essentially involves screening about 30,000 women in several hospitals in England, in Spain, in Greece, in Italy, in Belgium, identifying the high-risk group through the FMF algorithm, a combination of maternal factors, the measurement of uterine artery pulsatility index, mean arterial pressure, and maternal serum placental growth factor, and then randomizing these women into a group that receives placebo and another that receives aspirin. The dose of aspirin should be 150 milligrams. The drug should be taken at night. The medication should be starting at 11 to 13 weeks and through to 36 weeks. And the primary outcome of the study is preterm preeclampsia. Women delivering before 37 weeks with preeclampsia. We did the necessary power calculations and we estimated that in order to achieve significance with a power of 90%, we needed to randomize 1,600 women. The enthusiasm of the various participating centers has succeeded in having this recruitment within a period of 9 months. And throughout this time, we were monitoring the performance of the various biophysical and biochemical tests, and there was a very close coordination of the study. So we carried out screening in nearly 27,000 women. We identified as being at high risk 11% of the population. High risk was defined by a risk from the combined test of more than 1 in 100. Of those women that were eligible, we had a very good uptake of nearly 70%. And importantly, the compliance with the medication was very good. 86% of the women took more than 80% of the tablets that they should have taken. So the results of this study will, in one way, confirm the value or refute the value of screening in the first trimester and the approach of giving the appropriate dose of aspirin to women starting from the 11th to 13th week scan right through to the 36th week of pregnancy. And now the results. The use of aspirin was associated with an 80% reduction in the rate of preeclampsia before 34 weeks, a 63% reduction in the rate of preeclampsia before 37 weeks, preterm preeclampsia, and a non-significant 5% reduction in the rate of term preeclampsia. So after several decades of discussion as to whether aspirin is useful or not, the dose and the timing, I am very happy to conclude that women should be offered combined screening at 12 weeks, and the high-risk group should be treated with aspirin 150 milligrams per night, starting from 12 weeks through to the 36th week of pregnancy, with a major expected reduction in the rate of preterm preeclampsia. Of course, a major reduction in the rate of preeclampsia does not mean that you have now eliminated the disease. And I expect that many more studies will be carried out looking at different medications for different subgroups of the population. For example, we have a subgroup of women that are very obese, and we know that the rate of preeclampsia increases with maternal weight. And in a study that we reported last year in the New England Journal of Medicine, we had shown that in such very obese women without diabetes, we can reduce substantially the rate of preeclampsia with the use of metformin. Also, last year we have seen the publication of a very preliminary, a pilot study, a very small study on the potential value of pravastatin in the prevention of preeclampsia. Future studies will define whether the use of pravastatin, in addition to the use of aspirin, can have a further reduction in the rate of preterm preeclampsia. Or, unlike the case of aspirin, where it is not effective in the prevention of term preeclampsia, it may well be that pravastatin will be successful in that respect. We will soon be starting a major study of screening now for preeclampsia in the 35th week of pregnancy, specifically targeting term preeclampsia and investigating whether the use of pravastatin would be effective in the prevention of term preeclampsia. So I want to finish by summarizing a 20-year trip in many respects in fetal medicine, where it has become apparent that women should have screening not only for chromosomal abnormalities, but also for pregnancy complications at the beginning of the pregnancy. And on the basis of such screening, define an individual patient risk for a series of different pregnancy complications. In my mind, after such a long trip, it is now very clear that in the context of preterm preeclampsia, it is critically important that all women should be offered the combined test at 11 to 13 weeks, and the high-risk group should be treated with aspirin. Of course, research does not finish here, but a new era of further studies will begin. But what has been completed is the story of aspirin, the selection of the high-risk group, the dose of the drug, and the onset of its administration. Thank you.
I would like to thank Professor Nicolaides for the presentation. I would also like to thank everyone else for attending in our video lecture. Thank you all and have a wonderful day.